Okay, we'll get started and just kind of let people drip in. So again, thank you all for coming in for this next panel. I think we're going to switch gears a little bit, and I'm extremely honored to be here with my fellow panel, all coming from top healthcare institutions. So I think for me, I'll give you a quick background. I still feel like a new kid sometimes in healthcare. I've been at AMN Healthcare, which is the largest healthcare staffing and workforce solutions organization in the US, been there 9 years. My background though is not healthcare, and I still sometimes believe I'm a student of healthcare. I grew up working for Disney, and then I worked for Tribune for a while out of Chicago, obviously, and then H&R Block. So I still feel kind of like a new kid to healthcare, but I'm learning and have gotten to know these three panelists over the last couple days, and I think what you'll learn today is that they have unique challenges. Everyone's dealing with staffing and talent war issues, everyone in the room, but I think what I find incredibly interesting about healthcare is literally without their staffing needs met, they can't open their doors or really perform the service for the business that they're in. So thought I would start with something a little humorous, since it's been 3 great days of education. So I'm gonna give you a little story about one of these 3 people, except you're not gonna know which one. I asked them to give me a word that describes something fun or unique about them, and then I'm going to let them introduce themselves, and then I'll tell you which one was which at the end. So one of them described themselves as a laundry guru. They apparently do all the laundry in their house for a house full of people. Another one of them is speed racer, and I'll talk a little bit about what speed racer means later. And the last one of them is a yogini, who does their best work when they are standing upside down. So anyway, I'll start right here with Adrian, let you introduce yourself, Adrian.
Good morning, everyone. My name is Adrian McCoy. I'm the Chief HR Officer at Baptist Health South Florida in Miami, hospital system that recently opened a cancer institute. We have several different hospitals. We're going through a lot of transformation. I've been in healthcare, I've been saying 20 years for the last 10, so it's probably time to upgrade that a little bit, but I've been in healthcare my entire career, and happy to be here.
Good morning, my name is Mark Palaio. I am the Vice President and Chief Human Resources Officer for Henry Mayo Newhall Hospital in Valencia, California, which is about 30 miles north of downtown LA. We are a standalone, independent, acute care, level 2 trauma hospital. Over the past 10 years, we've doubled in size, and within the last year, we broke ground on a new tower that's actually going to increase our bed capacity by another 50%. So we're experiencing tremendous growth in our area.
Good morning, I'm Jane Maxud. I am the Senior Vice President and Chief Human Resources Officer for the Mount Sinai Health System in Manhattan. In the last 3 years, we've doubled in size. We have 7 hospitals, a school of medicine, and I'm responsible for human resources across all of the facilities.
And all of you have trouble sleeping at night, but that's a different issue. So just all comedy aside, so any idea laundry guru? Yeah, that's Mark. Mark, you want to tell us why you're the laundry guru in your house?
Well, I have a house full of women, or females, so nobody else took the job of doing laundry, so I got it. And my kids actually call me Laundry Boy, which is also my hashtag at Laundry Boy for my Instagram. Okay. So
I love that.
I'm defaulted as the laundry guy.
And Jane is our yogini. Tell us about that.
I am passionate about yoga. I've been doing yoga for years, and I've also started a wellness program at Mount Sinai very recently, and among yoga, Pilates, mindfulness meditation, and other forms of opportunities to engage the staff, yoga has been particularly successful, and I do a lot of my best thinking upside down.
Love that. Last but not least, certainly Adrian, I love her story, talked about your husband being a serious athlete in college as well, and not necessarily your strength, but somehow calling you speed racer because you were the typing champion of her state. Went to the nationals when you were how old?
About 18. It's really a sad story, and it's taken me this long to find it funny. But the reason I got into healthcare is I was, as some of you may have heard the other night, I was a temporary secretary, and I just intended to show up in an assisted living facility for the summer in between semesters at school, and ended up staying there for 13 years and developing a tremendous passion for what we do in healthcare. So, yeah, I'm not an athlete of any sort. People mistake me for a basketball player sometimes because I'm tall, but athleticism is only in the fingers at this point.
I love it.
So.
Thank you all, starting us out on a humorous note. So, but I did want to switch as we're starting to go into this panel, really talking about staffing and talent-related issues to healthcare. So I'm going to give you just a few facts that some of you may know and some may be new. Not probably unique to your businesses. Again, healthcare, 50 to 60% of healthcare-related costs are in labor for all these individuals in their hospital systems. And most of you know macroeconomic drivers are causing the big shortages. You read about this all the time of clinicians. So with our aging population, you all know baby boomers as they're getting older. Over age 65, individuals have a 3x more chance of being in the hospital using obviously additional care. Over 75 years of age, 4 times the amount of time you're visiting the hospital. Again, when you're thinking about the challenges that all of you have that are not in healthcare, thinking about if your main core staff for all of these individuals, for the most part, is nursing, is what I know keeps most of you up at night. 50% of RNs are over 50 years of age. And 62% of RNs over 54 plan to retire in the next few years. And about 40% of physicians are over 56. So again, some really big challenges, because again, can't operate without that talent in their hospitals. And as an industry, we are not replacing those roles fast enough. So the first question I was going to ask you today is really about technology, or how has technology helped you with attracting and retaining talent? And one of our kind of subtopics here around the sky is not falling is really thinking about what strategies you're using, including partnerships. Maybe there's organizations in this room you're using or not. And have you had any partnerships that have helped you? And if not, obviously that's fine as well. But trying to figure out when is it important to add a partner, if you have, and if that's been successful. So Adrian, I'll start with you on how has technology aided you in attraction and retention?
Sure. I think one of the challenges that healthcare is facing right now is just the ability to have the financial resources to engage with partners. So we've had to be a little bit creative. We've tried things over the years when it comes to predicting success for candidates, having different assessments, having them do those. We've partnered, and then in some cases, if we haven't found the value or the return on investment in those partnerships, in that our turnover gets down to an acceptable level, then we have to make a decision and decouple from that particular partner. But what I am finding with the number of different providers that are knocking on our doors, whether it be engagement, employee assistance program, everyone is trying to tap into the idea of social and the idea that our employees, in order to keep them engaged, they've got to stay connected, not just connected to their leaders, but connected to each other. We see it when we think about social recognition. We see it when we think about how to leverage talent across an organization. How do you use that those resources to be able to identify people and what their skills are and what goals they're trying to achieve across the system? So I think we found over the last 5 years that a lot of the providers that we've spoken to have been trying to harness 2 things. One, the social aspect of connectivity and the value of that, knowing that the demographics are going to change and people are connected right now outside of work. And second, how do we get the right information at the right time in order to make the right decisions? In healthcare, we've known over the years that we've solved a lot of issues by just hiring more people. Just the volume of patients usually cured all ills, we used to say. The more volume you had, then you could have more people and everything worked out. But right now, it's more important to identify that you have the right person in the right job that we are evaluating them effectively, that we're providing them just-in-time learning to develop. So technology is sort of woven throughout everything at this point that we do.
Yeah, no, absolutely. I was thinking in the earlier session today about quality too, because right, you were talking about we have to have staff, you have to fill them, you have to get them there, but if quality ever wanes, that's such a bigger issue in healthcare than anywhere else, for sure.
Right. As someone said, if we don't make the right decisions in healthcare, people die.
That's right.
So it's a little,
Risk is a little bigger.
yeah, it's a little serious.
Mark, I know when we spoke earlier, I love the awards or how you've been acknowledged as a hospital. You are the most wired hospital. That's a accolade that you've received. Tell us about that.
Yes, 3 years in a row now we've been Most Wired Hospital, which really recognizes our investment in technology. And primarily our investment in technology, like many hospitals, really supports patient safety and patient care. If we can reduce errors, if we can automate processes like medication administration, barcoding, and things that make it a safer place, it's a big win. I guess secondarily to that, it is also attractive for clinicians, technical folks, different healthcare careers to come work at our hospital because they're interested in that newest technology, and they want to be part of it. Whether they're millennials or up to baby boomers, they really enjoy or thrive on new systems and new ways, more automated ways. So we figure that that's a big attractor and that sets us apart from other folks.
No, I think that's great. And obviously California, you're in a heavily competitive area with all the hospitals in LA.
Yes.
Yeah.
I know under the ACA and meaningful use, we are incentivized to implement certain levels of systems. We do receive incentives, some financial incentives, but again, it goes much more beyond the finance. It goes most towards patient safety.
Yeah. Excellent. Okay, Jane, thoughts on technology?
We actually partner with Ascendify that sits on top of our ATS system so that we can engage in social media. And we draw in candidates who want to join our community separate and apart from the individuals who apply for a position. So in any given month, we get between 40 and 50,000 applications, and we get between 10 and 12,000 people who want to join our community. In addition to that, when we run large open houses, especially for difficult to fill positions, and I'll use genomics as an example, we will run a scientific seminar that we live stream at the same time that addresses the application of big data in healthcare and how we use that, because we're interested in engaging the passive candidate who may be very happy where they are right now, but we want them to think about us when they're looking for their next opportunity. We've also dedicated some of our recruitment staff specifically as sourcers, and they spend their time nurturing relationships, sometimes for up to 2 years before that individual actually comes to work for us. And that's done through social media and regularized contacts and providing content that a particular individual may find to be valuable. And we find that that's been very helpful in helping us to keep a pipeline going. You mentioned previously the shortage of physicians and nurses, and there's a particular draw in Manhattan for nurse practitioners and physician assistants, and the competition for that talent is particularly steep. So we currently have relationships with 36 different schools that graduate physician assistants, and we have 2 of those schools who currently have their practicum at Mount Sinai, so that we establish a relationship with that talent pool in advance of our needing to hire them and in advance of their looking for work, so that we're hopeful that we can continue to interest them in what makes Mount Sinai unique and make that a particular draw for them as they take the next steps in their career.
No, that's great. You kind of jumped into the next question, which I appreciate. When you're dealing with these critical talent shortages, you gave a few examples. Anything else, Jane, that's unique or you're trying that seems to be working really well on just recruitment strategies in general, in addition to what you just talked about?
Some of the other things that we're doing is a number of years ago we partnered with DDI, Development Dimensions International, and we specifically worked with the chief nursing officers of all of the facilities and got them into the same room. And I don't know if you're familiar with DDI, but they use a card sort methodology which selects the competencies for particular roles. And we had the nursing leaders determine what the competencies would be for each of the nursing positions across all of the facilities, so we would provide some uniformity. We then trained the managers in that methodology so that not only the recruiters but the managers look for that approach when interviewing a candidate to identify not only the technical skills that distinguish them for a position, but also the behavioral skills and personality types that will be a good fit for the job that they hold in the particular institution in which they work. We've recently begun a beta pilot with a company called Arena, formerly known as Pegged Software, and they apply big data to the selection of talent and demonstrate in the 400 hospitals they've worked with before they're partnered with us that they've been able to decrease turnover in the first year by an average of 28 to 30%. It takes them about 6 months to develop an algorithm that's appropriate for the particular institution with which they're working. So we've just completed that 6-month mark, so I can't tell you whether that's actually going to be helpful or not. But in the next 6 months, I should know more about whether that combination works well. And the last piece is we are teaching, and we're again working through nursing, the notion of panel interviewing rather than sequential interviewing. So rather than having a candidate have 10 interviews, one right after the other, where in all likelihood they get asked the same 10 questions by each individual in succession, we want them to be interviewed by the individuals with whom they're going to work to see if that chemistry exists before we bring them in. We also want the candidates to improve, or the managers to improve their ability to interview people, because it's my experience, and probably all of yours, that everyone thinks they're a fabulous interviewer, and unless you're really skilled at doing that, you probably don't dig deep enough into understanding a lot about the individual. Rather, you search for surface commonalities and decide that someone's like you, so therefore they're going to be a good fit for the role. And the panel interview approach involves getting the group together, having them pull out the competencies for the role, determining which questions they need to ask in order to determine whether that individual possesses those competencies, working with a rating tool that they have to complete in real time, and then ranking the candidates so that they are in a position to make a far more objective assessment about someone than they might otherwise.
I love that. I'll be anxious to hear if that's going to change any of your statistics. We're starting that a little bit on the AMN corporate side. Behavioral event interviews, we had some of them out there, but to your point, you have to teach individuals who don't interview every day, all day, and then we've been kind of slicing up our competencies as well and see if we're going to get a better quality of hire. So I'll be anxious to stay connected with you on that as well. Anything else, Mark, on recruitment strategies for you that you're trying out?
Yes, labor shortages are going to be probably in healthcare, probably the highest ever in the next couple of years. We got a short break during the recession where nurses and clinicians put off retirement because they had a spouse that was out of work or they needed to support other family members. So we're going to see some critical level shortages coming up. What we've done at Henry Mayo is we looked a little bit forward and we thought, we strategized on how we can reinvest into clinicians. So what we've been doing is we've been adding clinical educators pretty much in each individual service line, med-surg, telemetry, lab, et cetera. And those are really our long-tenured nurses, our long-experienced nurses, those nurses that may be thinking about retirement because they're tired, they don't want to be on their feet all day, and move them into more of a leadership position to train other nurses. So they have really two jobs now. They not only have to work with the current nursing staff to make sure that their competencies and their training is at the highest level, but also they work on internal specialty training programs. We have 3 areas, and most hospitals are really the most difficult areas to fill, and those are in critical care, emergency, and operating rooms. So these clinical educators, we provide career development opportunities for those in med-surg and tele to move up and get more experience and education and moving them into those more critical roles. So it helps us because now we're filling those roles, but it also helps us because we're reinvesting in the staff that we have, or we're investing in the staff we have. So we find a lot of value in that. Also, the increased use of clinical internships with the schools. Nursing is a big one. It's always been a big one for us. We have a college right down the street that we partner with. But now we're looking at other specialties like clinical nurse scientists, imaging folks, respiratory folks, and again, hosting those rotations on site. So we can not only groom students to be prepared, but hopefully if we show that we have such a great work environment, that they'll choose to use us after they graduate. We spend a lot of time and money on career development of our staff. In healthcare, we have this, we always promote the best nurses and the best clinicians, and we never prepare them for leadership and management. Right. And then a lot of times they fail. And it's really a sad story because we made them fail. Yeah. So we're doing a lot more work in career development, succession planning, and even leadership development for these up-and-comers.
I love that. You're looking at the top of your population and the bottom, right, to bring everybody in new. And I have some passion, too, around kind of this concept of pre-retirement, that, trying to get a nurse, to your point, who's tired and they've been on their feet for years and years and years and they want to do something different, maybe a nurse educator, maybe even either dropping to kind of a part-time or a job share status, something to keep them as long as you can, while they obviously can still provide quality care. But I know just thinking of different ways to help them stay in the workforce, but yet full-time is going to be more and more challenging for them. So I love that you're coming up with creative options. Anything else, Adrian, on creative recruitment strategies?
I think one of the things that's been a little bit unique for us is engaging our leaders in leveraging their network to connect with people to help us recruit. Sometimes when leaders don't have a critical opening, they're not as engaged in the process right now. So we've been leveraging LinkedIn when we have something great going on in the organization. We ask them, as well as our recruiters, to just send it out, just start marketing what's happening, whether we have a new facility opening, whether we've won an award or something great has happened. Just have an ongoing conversation about Baptist Health. Not that people in the South Florida market don't know the organization, but just to keep us front and center in the network in terms of what we're doing, what we're accomplishing, to make people at the right time connect with Baptist Health for their next employment experience. And I think that's been very helpful for us, not just going out and sourcing directly and competing with our pretty tight market right now in South Florida, but engaging our recruiters and becoming marketers of the organization overall, not just the particular job that they are recruiting for.
Yeah, it's one of those kind of branding issues that you probably have to watch every day, because I think about a nurse can leave at lunch if they even happen to have a break and
Sure.
get a different job while they're out.
Right.
It's that easy to lose them. They can literally go anywhere and walk in the door. So we talked about recruitment strategies, but then let's take that down one more level to really staffing. So you're staffing every day, having to deal with shortages over here, overtime, moving people around, float pool management. And I know we talked a little bit in advance about both dealing with daily staffing challenges and also how you and your team's role has evolved. And I was thinking about the CHRO panel that was up here yesterday, also talking about HR's role evolving, but to more alignment with the business, obviously to be speaking clinical language every day, but would love to hear a little bit about dealing with staffing challenges. So Adrian, you want to start?
I think one way that we found that's been very critical is to not simply take in a bunch of requisitions consistently and then pull our hair out trying to fill them. At some points, we've got to become more consultative and go out and sit down with the leaders and talk to them about what they need, not just for the particular job, but what are they trying to accomplish in their departments, and do they have the right talent? If we can't find that talent, what other options do we have? Mm-hmm. Do we outsource a certain function? Do we need to contract because they're having a surge for a particular period of time, as opposed to just bringing in a lot of full-time workers? So we've been spending some time, and this is where data comes in, where you start to present to them what their trends look like, what their turnover looks like. We even implemented something recently where we track regrettable attrition. as opposed to just turnover. When a leader puts in a termination, there's a little pop-up that comes that really says, does this one hurt? Not literally, but is this person going to be hard to replace? Because if you just look at voluntary and involuntary turnover, that doesn't tell the whole story. If this person that's leaving was here for 30 years, has a tremendous amount of knowledge, or if this person could do the work of 3 people and now you've got to turn around and hire 3 people, that's something we need to keep track of and look at it a little bit more surgically than we've been looking at turnover in the past. So that's how we provide that consultative advice. We try to get more data around what's happening, as opposed to just allowing leaders to say, well, someone left, just go find me another one. Right. Because that's very easy to do. The minute someone resigns, we go to the computer, we put in a new requisition, and we don't pause to say, do we still need that? Or do we have someone who's been begging for additional work, opportunity, project that you could provide some financial incentive to and give that work to them? So healthcare has been pretty much on autopilot when it comes to staffing, in terms of someone's out, put someone back in. But we've got to look at it differently, because we're moving from volume, being paid for volume, and we're really looking at value. What is the value of the care that's being given? And if you have a lot of readmissions, you're not going to get paid for that. So you've really got to look at the talent and make sure they're delivering the best quality care. So that provides a huge challenge to HR to not just be order takers, but to help strategize on what's really needed for the business.
What would you say, just follow-up question, on the readiness of your department heads, for lack of a better term, in asking them to be even conversationally predictive, like trying to get in front of it? Because I know that's, again, to your point, it's a new muscle, right? Both your team is growing and theirs, and even just to your point, the mix about full-time versus contingent, or to your point, every time someone leaves, do you have to fill it? How do you think differently? So the readiness of those conversations.
I believe there's a huge gap there within the healthcare industry, because all of the leaders have not grown up that way. They've just been able to in and out, and as long as the care is being given, there's no one necessarily holding them accountable. But what's happening in healthcare, you have a lot of people coming into the industry, out of industry, that are really challenging us to think differently about how we're making these decisions. And it's from a leadership development perspective for HR, and definitely when it relates to talent management and succession, having the right leaders that understand how to make those decisions is critical. And the last thing I'll say about healthcare, I love healthcare, but we're very paternalistic. We're very loyal. We've had people that have worked with us for a number of years, and sometimes they don't have that skill, and it's very difficult to build. So in HR, we have to keep challenging that and making sure that we're providing them the resources to think differently about how they staff, about how they plan, and about how they look ahead to the future.
And I think certainly tying it to cost and quality gets their attention, versus it would just be a nice to do, for sure. Jane, any comments for you on just your dealing with your daily staffing challenges?
Yeah, I'd like to touch on something both Mark and Adrian said, and that is the first thing is many of the individuals who are promoted into roles aren't prepared to be in those roles. So you've been a great clinician, but you don't really understand a lot about running a business. You know which other kind of clinicians you need to care for patients, but you don't think about how do you look at your staffing plan? What do you do with your budgeted dollars? Do you think ahead in terms of how the work is going to change, how the care delivery is going to change, and what skill set you're going to need to manage that? So we've put in leadership training, and I'm adding now very specific modules in things like budget management, which you would presume that when you hire somebody that has those skills that they actually come with them. But I've discovered that the way we do budgets, it's not necessarily the way other people do budgets, so you actually need to train them to function in our environment. In addition to that, we are really focusing on the HR business partner role, so that the individual who is formerly known as the recruiter, really spends time in the department with the department leadership, not with the administrator, but with the actual leader. And I've gone to leadership meetings and talked about the fact that we can't be interacting with your secretary. We have to be interacting with you, because your secretary doesn't know what you know. And we need to understand what your plan is for the next 5 years. And are you aware of the demographics of the people in your department and who might be thinking about retiring? And what is the diversity of your department? And does that mirror the diversity of the population that you're serving? And what kind of competent care around diversity are you actually delivering? And what does your budget say relative to the opening that you have? Because I got a phone call the other day from somebody who has a position that they want to fill, and I said, how many budgeted dollars do you have to work with? And he said $35,000. And I said, we're not finding you someone for $35,000. Let's talk about your staffing model. And I couldn't get him off it right away because he was focused on the fact that he had someone and now he needed another someone to plug into that spot. So getting people to think about the fact that the microcosm that they work in is their business and they own it and they need to run it as part of a larger whole has a lot to do, I think, with being successful with where we are right now. And when you discover that they don't understand what you're talking about or they don't have the tools to do that work, it's finding a way to help them understand that work, giving them the tools, and we don't have anything fancy to work with. Sometimes we're just thinking about working with a simple spreadsheet to sit down and give some thought to what you're going to do and what your future looks like. And we're happy to sit with you and see what we can do to help. We also have people, as Adrian pointed out, who've been with us for a very long time, and their skills don't necessarily translate to the way the work is going now. And what can we do to either improve their skills as they exist currently so that they'll be prepared for the opportunity that comes in the next year or two? And if that's not feasible, where can we find them an opportunity that'll be meaningful for them? Because we're certainly not looking to take someone who's been loyal and been a great employee and say that we don't want them to be part of the Mount Sinai family anymore. We want to find meaningful work for everybody.
Oh, I love that. You had great examples: career development, staffing needs, leadership development. Any thoughts? Just a follow-up question, Jane. When I think about people going into leadership, and several of you mentioned that doesn't always work, and the statistics are pretty crazy. Like 40%, last time I read, of folks that have gone into leadership don't necessarily love it, potentially because some of the demands they're being asked of that maybe they didn't think about before. Any kind of tips or tricks for screening as you're thinking about putting somebody into leadership or getting to whether or not, do you paint a picture of what that's going to be when they go into leadership for the first time, and any success stories?
Yeah, I like to give people the opportunity to actually work in the space for a day or two. So to give them the opportunity to spend time with the current leader or a leader if the current position is actually vacant, and give them real-time positions to see how, real-time problems, to see their thought process in terms of how they would plan to address that problem if they were the person in the leadership role. Understanding they may not have all the information, but what sort of questions would they ask and how would they think about solving the problem? And where would they go if they didn't have the answer to a question? Because that'll tell me a lot about what somebody's grit is like in terms of sinking or swimming. Somebody mentioned that it's tough to determine grit on paper, and I think that's true. And I think that a lot of days it's grit that gets you through your job, grit and the relationships that you've established. And if you are skillful at working well with people, and you're tough-minded, and because the first 12 answers were no, you don't stop at that. You keep going until you figure out how to get to yes. Your chances of being successful are pretty good. And are you the person who will reach out and say, I don't know how to do this. I either need to take a class, I need to have help, I need to have somebody who can partner with me, is somebody who's likely to go a long way, even if they don't necessarily come from the perfect pedigree on a piece of paper.
Excellent. Thank you, Jane. Mark, anything else new on staffing challenges that you guys are trying at your hospital?
Well, state of California has something unique called mandated nurse ratios.
Oh yeah, there's that.
And I think there's a couple more states that are following suit. So we have to staff to the ratio at all times. Mm-hmm. And at all times means when a nurse has to go to the lab to deliver a specimen, it's not at all times. when the nurse has to go to the restroom or take a lunch break or a break in general. It's at all times. So we have to make sure that we staff the unit. So when people call in sick or there's shortages, we're really out of compliance with the law. And we're called on it.
I'm sure.
So we try to do what we can to fill shifts. Kind of getting back into the most wired hospitals, we really continue to try to leverage technology for solutions. And my part of that is not only leveraging it for solutions, but also to improve engagement and satisfaction. So with our time and attendance and scheduling software, we do self-scheduling really throughout the house. All clinical departments and most all departments that have variations of schedules. So nurses and clinicians can go in there and schedule the shifts that they want, which takes the burden off leadership. And we do fill the holes after the schedule is closed or whatever to make sure that we have the right staffing in the right place, but it empowers them to be able to pick their own schedule. The other unique thing, or maybe not so unique thing that we do, but what we do is we allow clinicians to swap shifts without leadership intervention. There are rules set up in our time and attendance and scheduling system that if they are scheduled to work a day and they want that day off, there's a way to call a friend or text a friend or whatever and swap shifts, and we don't care, just as long as it doesn't create overtime and they're competent to do it. So really empowering the frontline staff to control their own schedule seems to help in filling a lot of those holes. Sure, we have extra shift bonuses. Sure, there's a way that we do shout-outs, texts, things, shout-outs saying we have some extra shifts, and that helps people plug the holes too. But that seemed to work pretty well for us.
Excellent. Great. Thanks, Mark. I do have one final question, but I did want to, we have about less than 10 minutes left, but I would love to take any questions for these panelists. Yes, back there in the corner. I don't know if we have a mic.
For Mark, about the swapping shifts, do you guys run into any union issues on seniority when swapping
I'm sorry,
shifts?
say that one more time, scheduling shifts?
Union seniority.
And seniority. Well, really, it's a first-come, first-served basis. And we are unionized for both nurses and everybody else. And as long, the only, I guess, filter is we give full and part-time nurses first crack at it, and then the per diem and the more casual employees second crack. But there isn't a seniority for that. Same thing with requesting time off, which we also do that online. It's really a first-come, first-served base. If they happen to input exactly at the same time, then sure, seniority would take preference. But it's really a first-come, first-served. The nurses and clinicians they have the ability to self-schedule online. And also use their smartphone to do that. And we found that we don't have to pay them for that. It's de minimis work. It's work that they would do anyway by submitting it on a piece of paper. But
Do you know, which system do you use for time management?
I probably should have done a shout out to CHROs because that's probably that is why I'm here today, because they did ask that I come and they did nominate me for an award. They are a true partner with us. They do our timekeeping, of course, payroll, HR, analytics, scheduling, absence management, and several other functions for us.
Great, thank you. Other questions?
I have a question.
Yes.
Hi. This is for Adrian. With the data that you collect around that painful turnover, have you been able to use that to change behavior or impact the recruitment process?
We've started it about 6 months ago. We implemented that, and we've been tracking it to show the difference between just the involuntary, voluntary, and the difference. It was actually one of our CEOs a couple of years ago that asked us to identify really how many high potentials were leaving. We looked at it on a broader basis. We haven't had enough time to really see, a significant difference to be able to highlight and go out to leadership and say, here's what we're seeing. We'd like to see a year's worth of data and be able to show that. And we've had a lot of other external issues going on in our environment as well, where we had a voluntary separation opportunity where we had about 500 people to leave us last year. So we're trying to sort of pull that out of it because that was interesting as well. And some of the after effects of that caused people to leave as well. So it's not necessarily clean data, but we're definitely encouraged by the fact that now we're tracking it and we're going to be able to look at it, but we're going to have to hone in specifically on those leaders to make retention a priority again. And that was just one strategy we decided to implement to start on that journey.
Thank you. Yes.
Hi. Regarding to the talent development, any of you have experience in developing talent from high school itself, like basically sophomore, juniors, when people turn 16?
Any high school programs for any of you?
The only thing that we do is, as it relates, we do have a career academy over the summer where students are able to come in. They're usually kids of either physicians or employees that come in and they experience healthcare or they have some exposure to it. But we have been able to hire several employees, several students through our Big Brother, Big Sister partnership, where we bring in Miami, we're the largest employer partner that brings in over 100 students a year. They come to all of our hospitals. They get mentored by leaders in our organization, and we have been able to hire several of them. You know, we give a number of scholarships, so ideally we want them to go off to college and not forget about us. But there are others that do get employed, not a lot, but a few. I do think that there is a huge opportunity for us to start to look at positions like medical records coders. I mentioned that in one of our forums the other day. It just boggles my mind that you can't find these folks nationally. And I think if we were to partner with the local high school kids and, you know, provide scholarships, some training programs in addition to their certification, we could develop a pipeline and really make a big contribution to the community. When you think about teenagers going out now trying to find jobs, I don't know how many of you have teenagers or millennials that are really trying to find work. There are great careers in healthcare, and I don't think we're doing enough to promote it in the high schools right now.
Hey, let me add to that. Although where we live, where we work, it's the 5th largest city in California. 89% of our employees live where they work, and the only reason why I say that is most of our talent is local. We participate a lot in the high schools. We go to the high schools and we talk about healthcare opportunities because these kids don't understand some of these careers that are in hospitals that are available to them. Respiratory therapy, for example, imaging techs, lab. These are jobs that don't require a lot of investment, but it gives them a short amount of time to go to school and then be introduced to a strong job. So it's that awareness. And I know you talked about that, Adrian, about the coders. That's another one. That is a field that's paid very well, and people just don't know that. And if they knew that, maybe more folks would get involved in those careers. So I think for us, in our hospital, we make sure that we participate in career fairs in high schools, go and talk to the kids, even at junior high level too.
Excellent.
Oh, we also, let me add one more thing. We also have a fairly large volunteer program. So it's between the ages of 14, of course, and 17. And so the kids have to commit to a certain amount of hours per year, and they come in and they volunteer for us. And that really opens their eyes to careers in healthcare as well as giving them the hours that they need to graduate or do whatever. But that gives them a taste of the hospital experience.
I love that. Just to
And then
see
they
it.
can look at different jobs and see, hey, that sounds interesting. Maybe I'll try that.
Yeah, no, I love that. It could be a craft spirit as well instead of if they're not necessarily college bound too. No, I love that. Anybody else? Any other?
Question on that. That's really great that you're working very closely with the junior high and also the high schools as well. Another quick question is, for becoming a CNA, because that's one of the areas people don't know much about, what is the age that you see in each of your states? Is it 16 or older? They have to be 18?
At our hospital, you have to be 18 to be a paid employee. But the volunteers can start as early as age 14. We do have CNAs at 18 and 19. It's a certificate program. A lot of them take it while they're in high school or the summer after high school. It's a certain amount of hours, and they can come to work for us.
Excellent, thank you. Any other questions? I think we're just at time. Excellent, great, thank you very much.